which is the first national imaging dataset that's available in the UK. We want to improve its use for, or potential use for, cardiovascular disease research by streamlining how we put together the application paperwork, sharing copies of that and exemplar documentation so that it's easier for people to apply for access, using the metadata and the reports to understand what's in the data set in terms of what imaging is there, what reconstructions are there, and also what diseases are represented in it, so that people have the numbers and the information needed to make grant applications to actually apply to use this data set, and also to share curation code and analysis code so that it kickstarts the research, so that researchers aren't doing the same repeated tasks again. So we've got 4 talks this morning telling you about what the data set is and what we're planning on doing with this. But the most important part of this is the discussion afterwards, because we want your input into what we're actually doing. So we do things that are of the most use to the research community who are interested in using this data set. So first up is Jackie Caldwell, who's going to give us an overview of the ScottisH medical imaging data set. So I'll just stop sharing my slides there. And Amy, you can share Jackie's slides. And Jackie, I'll hand over to you. Thank you very much indeed.
Thanks, Michelle. Good morning, everyone. I work for Public Health Scotland, and I've been involved with what is now called ScottisH Medical Imaging since 2014, when I made the business case to our Caldicot Guardians that we needed to have research-ready images available nationally from a one line in the grant for the FAR Institute. Next slide, please. Okay, so I'll let you read this. It kind of reflects what Michelle was saying about it's the first in the UK. So this was a DARE UK landscape review from October 23, saying that it's probably unprecedented in the UK, Europe, and perhaps beyond. So we're very proud of it. I'm very keen to get more researchers using it, and as Michelle said, make it easier for more researchers to get involved. Next slide, please. Okay, you'll all be aware of the routine care aspects. So in Scotland, we have one national PACS. So we have all the images that are routinely taken in the main hospital departments. And we've taken a copy of them. We have a copy from 2010 through to partway through 2018, which we have developed all the tools and the pipelines to de-identify them. And a lot of this work was funded through the Pictures grant led by Emily Jefferson, who's now at HDR UK. Next slide, please. Okay, so what we have de-identified now is MRI, CT, PET, radiographs, and nuclear medicine. And we have the tools we believe, to de-identify ultrasounds, but we've just not had the time to test out our code to make sure that they work, and that's partly because nobody's actually asked for ultrasound yet. We do have the structured reports for all modalities, however, so that diabetes researchers, for example, who just want to know that a liver ultrasound has been undertaken and what was the findings, so we can produce that. And we can produce the structured reports in 2 different ways. We can just de-identify the whole text, or we can use it to confirm, for example, that there is a tumour there, or that a stroke has occurred, and create new data sets, or new data, so that it's then easier to create a stroke cohort. Next slide, please. So in terms of the technical capabilities available to support studies using images in the Safe Haven, we've got DICOM viewers, we use Linux, Python, and R. We will shortly have access to a GPU cluster and also a high-performance compute. We're trialling a container execution service to support federated analysis. We're kind of in 2 minds about synthetic data to support AI development out with the Safe Haven, and then the container execution service would let you import code. However, what we are doing is creating dummy tabular data and dummy image data for now to assist with that. Next slide. We have a lot of governance controls in place in Scotland to access national data. The Public Benefit and Privacy Panel for Health and Social Care exists to approve applications, and they're weighing up the risks to people's individual privacy against the benefits from the research that's requested to be carried out. Each researcher going to work in the National Safe Haven has to sign a user agreement signed by them and countersigned by their head of department, somebody like myself in Public Health Scotland. There are various penalties for attempting to import malicious code, attempting facial recognition unless you're carrying out maxillofacial surgery research kind of thing. And the ultimate sanction is that, as well as the individual being banned from using the safe haven, their institution is also banned. And it's not an idle threat. We have banned an individual from using the safe haven. We're taking advantage of work done by DARE in the past under grey matter and SACRO in terms of how we can egress AI models that have been developed, because we know that some types of models can hold everything in memory. So we want to make sure that we are not disclosing, even though it's pseudonymized information. And we've got particular concerns just now around support vector machines and k-nearest neighbours. But we're working with kind of the researchers understanding the leading edge of this so that we can expand the different types of AI models that we can support. And of course, generative AI poses a whole set of challenges that we're starting tentatively to get to grips with. Next slide, please. Okay, so some examples of our current studies, just to give you a flavour of what's going on. The Field Long study you may have heard about a few years ago in the media. It's a cohort of professional rugby and football players that we've now linked to their imaging, and they're exploring the risk of dementia. The PI is a neuropathologist, and he has some theories from the postmortems that he's done about a certain area of the brain that changes and is associated with dementia. So if we can get earlier detection of dementia, that can only be a good thing. CT Clock is validating an existing algorithm, estimating the time of stroke onset from the metadata in the images. Will, who's on the call, leads the Warbler study, which was looking at all the structured reports and trying to do epidemiology on them. HEAD TBI is another dementia-associated study. Brain Health Data Pilot, another one that Will's leading in conjunction with HDR UK, and a parallel study with Moorfields, again into prevention and treatment of dementia. And the University of Edinburgh worked with high street optometrists to collect retinal images from them. And they've created this data set, which we've proved that we can link to other health data. So they've got 2 exemplar studies on the go just now. Next slide, please. Okay, however, also not sweetness and light. Since the Pictures grants ended, we are kind of in need of more funding to expand what we can do. And of course, since the Pictures grant, we have learned so much, and there are things that we now understand that we want to do, but we need to get funding. We have some grants in the pipeline that we're hopeful will help with that. There are also plans to update the archive and to have an ongoing ingest from national PACs so that we're no longer constrained to 2010 to partway through 2018. However, this has all been complicated by a reprocurement of national PACs in Scotland and the move to a supplier in the cloud. So IG colleagues are stressing mightily about all of these aspects and considerations. I've mentioned what we're doing in terms of egress of AI models. Just as you'll all be aware, the rapid pace of change in AI capabilities, every day there's something new coming out, just as you think you might have got to grips with your previous level of knowledge. There's also a lag between regulatory and governance controls keeping up with the pace that AI is moving at. We have a very few studies that have published. Will's hoping to publish quite a few more very soon, so that will give us a higher impact and profile and should attract more funding as well. And there are challenges within NHS Scotland and Scottish Government about how well we can support innovation and through working with industry, but there are working groups associated with unlocking the value of public sector data and benefits valuation and negotiations, who negotiates the benefits into the NHS, etc., etc. Next slide, please. Okay, so Will produced this slide for us just to show some of the learning that he's had from working on his studies.
Happy to talk to this quickly if you'd like, Jackie.
Very, very briefly, Will, because I think we can share it more in the discussion because everybody's going to be together in the discussion.
Okay, so just to quickly let everyone know how kind of brain health might be an exemplar for this. So funded by a number of funders, what we sought to do is to create an evergreen data set, so one that can be shared by, used by multiple researchers and improved over time. So the first thing we've done is try to streamline the very lengthy PBPP application. So we've done that for a constrained set of purposes. Make sure we have permission for user-generated outputs. We're going through currently the permissions process for container access, which will make international collaboration a lot easier. GPU cluster we're aiming to get in the first half of 2025. We've got an ongoing patient and citizen engagement program. So our two roles really are to try and enrich these data for epidemiological analysis. So at the moment, we've run a rules-based NLP across all the brain imaging reports, which gives us about 24 phenotypes in about 650,000 reports. But of course, the intention is to try and get those phenotypes from pixels. So that's in progress to get some standard brain imaging pixel-based phenotypes. And we hope to have those ready by early March. And then linkage to other cohorts. I suppose the second thing is to try and reduce people's time to prepare data sets. So the first thing is, because these are rather large and dirty data sets, to try and standardize the image selection, make sure we can reliably identify, for example, sequence, artifacts, and other things. So we've got a pipeline based on DICOM, image, and text. Standardize the image preparation. So we've got a pipeline for standard brain imaging preparation. At the moment, it's in progress. And then an FTSA and Swarm, two types of containers we're just getting approved at the moment. So we've got some projects ongoing about basically trying to identify people who are at higher risk of stroke and dementia based on covert cerebrovascular disease. Try and improve our classification of disease like dementia and stroke in electronic health records, enriching with the text-based reports, and lastly, comparing 3 AI-based methods for dementia prediction. And that also addresses Jackie's point about commercialization, where we've gone through a discussion with a number of stakeholders. So happy to talk about that later, and thanks for just giving me a moment to outline it. Back to you, Jackie.
Okay, so that's really all I wanted to say just now, and apologies, Michelle, that's us 2 minutes over time.
Fantastic. Thank you very much indeed for a fantastic overview of the Scottish Medical Imaging Dataset and what's been done there. I'm now going to hand over to Jonathan Weir-McCall, who's going to talk about what you can do with routinely collected imaging data and metadata to give you an idea of the sort of things we can do with this and the sort of things this could then be used for in future research projects by the community. Jonathan, over to you.
Thanks, Michelle. So This is where are we? Yes, so this is an overview of what can potentially be done. This is work that I conducted with Michelle in the English database, but hopefully one which we're going to bring to Scotland, where we have access to so much more granular data, and of course the DICOM data, which is incredibly exciting. The trigger for the prior study was that we had, led by Michelle Williams, David Newby, and others in the team in Edinburgh, we have the ScottisH study, which showed that cardiac CT reduced the event of non-fatal MIs and cardiovascular death in those presenting with stable chest pain. The only challenge with this, as with almost all randomized controlled trials, is that these are driven by non-fatal events, because fatal events are are rare in cardiovascular trials. To do this, you need incredibly large studies beyond the scope of most funding organizations, but this is where national data can potentially come in, and something we wanted to address within the English data set. So we, of course, pooled the Office of National Statistics data, hospital episode statistics, digital imaging data set, which just records the occurrence of scans rather than the wealth of data that DICOM level data can give us. Whenever we looked at behaviours over the years, so this is an examination of 1.9 million examinations occurring between 2012 and 2019 within NHS England, we saw marked growth in the use of imaging for coronary artery disease, with the most rapid growth seen for cardiac CT. And the dashed grey line there was the introduction of the NICE guidelines, which recommended the use of cardiac CT in stable chest pain. Now, while there's an apparent upswing there, we of course wanted to understand if that was mechanistic or perhaps related to the ScottisH study, which had come out in 2015. And to do that, we used a time series analysis. And this essentially takes all the data prior to the event of the guidelines and says what would have happened if this guidelines had never happened based on previous trends, what would the continued growth have been? And then it compares it to actual growth. And whenever we look at this, we can see that the actual growth post guidelines is much more rapid than the modelled anticipated growth, which are the dark grey lines here. So we can see that the guidelines resulted in a significant upswing in the use of cardiac CT and a significant fall in the use of invasive coronary angiography with stable utilisation of functional tests. What was incredibly interesting to us was we saw marked heterogeneity in the use of cardiac CT across healthcare regions in England, both in the use of imaging and in temporal changes in cardiovascular outcomes, particularly in cardiovascular death, as we can see in the histograms here. Now, while there's many reasons hospital A might see improved outcomes unrelated to imaging use, whenever you start to aggregate all this data, you can perhaps start to get a feel for common trends across the regions. And what we consistently saw was that as growth and utilisation of cardiac CT grew, cardiovascular mortality fell across these regions. Now, there was some criticism of this. It could be just that centres with greater access to CT had greater funding and resources and can do all sorts of other exciting things that also reduce cardiovascular death. So I said, fair enough. What about cardiac MRI, which is twice the cost of cardiac CT? What does it do for outcomes? And we see no such association between cardiac MRI use and change in cardiovascular mortality. Now, of course, correlation does not equal causation, but fortunately, we do have the ScottisH trial with the 10-year data now published in The Lancet just 2 weeks ago that show that this is a causative mechanism, and we've just used the national data to extend these observations from non-fatal events to fatal events using the power of large numbers. As has been touched upon by Jackie, there's a lot of strength in the SMI dataset, both with the DICOM data and the DICOM metadata. And this can range from the incredibly simple and banal through to the complex stuff we heard from Will on the use of the DICOM data for AI. But I'm just going to focus a little bit on the DICOM metadata just because it's quite simple and graspable and easily accessible. And one of the most simple things you can do with this is simply confirm a scan has occurred. There's a separate study we were conducting in England of cardiac CT where we found that between 3 and 5% of cardiac CTs that existed in the national data sets had not actually occurred. And this was due to a huge number of reasons. The patient could get on the table and then feel incredibly claustrophobic and abandon it, but they still get a report that says scan was abandoned. So this is documented as an event on their healthcare records. Alternatively, they could have had a contrast reaction and abandoned at that stage. They might have got their non-contrast scan, but not their contrast scan for reasons of extravasation. So with the DICOM metadata, we can actually understand what's truly occurred rather than a sort of surrogate marker of what may or may not have occurred. Using DICOM as an exemplar of how DICOM metadata can be used. This is a study we conducted a couple of years back now of a firm that combines AI and computational fluid dynamics to assess whether a stenosis within a blood vessel is flow limiting or not. And this can then be used to guide downward stenting, and we can appreciate the flow drop in this middle image and a subsequent stent into the LAD there. Despite the best efforts of the AI firm, only about 90% of scans sent to them could actually undergo analysis, with the most common reason of this being inadequate image quality. And we just wanted to understand what factors drive this using DICOM metadata in this cohort of 13,000 patients. And we found that scanner mattered. So if you've got a wide detector that covers the whole heart in a single volume acquisition, you have better chances of your images being analyzable by the AI tool. Similarly, if you've got an incredibly fast scanner that acquires the heart, this improves your likelihood as well because it stops the coronaries moving during the image acquisition, or sorry, captures it, giving the coronaries less chance to move. Heart rate's incredibly important and isn't captured in much of the metadata. So if we drive for optimal heart rate control with heart rates below 60 beats per minute, you have a greater than 90% chance of your images being able to be analyzed by this tool, whereas that progressively drops the higher the heart rate. How you reconstruct the data also appeared to matter. So we found that as the field of view is reduced, which improves the pixel size resolution, the greater the ability of the AI tool to process the imaging data. And this is counterintuitive to us as humans because the images get noisier, the finer and the smaller the field of view, so they look less pretty, but it seems that the noise is less of a factor for the tool. So in conclusion, DICOM data and metadata provides granular scan level data. The national data, of course, provides broad outcome data, giving us a unique opportunity across SMI and the rest of the Scottish national data sets to bring these strengths together to answer some really interesting questions. I thank you all for your time.
Fantastic. Thank you, Jonathan. A really nice example of the importance of nationally collected data and the importance of things in the metadata. It's not just about the pictures, it's about the information in the pictures as well. There's a lot of stuff in there. You focused in on coronary artery disease in your research, but hopefully for everyone on the call, you get the idea of how you could do similar or slightly different things for your areas of interest: cardiomyopathies, heart failure, all these other cardiovascular diseases, aortic aneurysms, peripheral vascular disease, many questions that could be answered in these data sets. So I'd now like to hand over to John, who's going to talk about data curation and project support from the British Heart Foundation Data Science Centre. John Nolan, over to you.
Thanks, Michelle. I'll just start by sharing my screen. Oh, people have disappeared. Can I check that everyone can see the slide on screen? Okay.
Yep, we can see it grand.
Oh, brilliant. Thanks, Michelle. So yeah, good morning, everyone. So yeah, I'm John Nolan. I'm a senior health data scientist with the BHF Data Science Centre. And as Michelle mentioned, I'll be talking about data curation and project support in the centre, and how our health data science team aims to provide support to the Scottish medical imaging work. So I'll start by introducing our team. So we are a team of 9 data scientists, and we work across multiple research environments, all of which are set up differently with different softwares, and we've built up knowledge and experience of working in these environments and of working with electronic health records from across the UK to support researchers. So Lars, who's on the call with us today, and myself, we will both have access to the Safe Haven, and so be able to provide hands-on data curation support to the ScottisH Medical Imaging Project. Our team provides data science support to all of the various work themes of the BHF Data Science Centre, but so far, in particular to the whole population data theme, where we provide data curation support to researchers carrying out projects primarily in the CVD COVID UK COVID Impact project and in the DataCan project. And for those who are not familiar with these projects, these are projects that aim to explore the impact of COVID-19 on cardiovascular disease and cancer, respectively. And this slide shows the data provisioning dashboard to give an idea of the breadth of data that we work with. So primary care data, secondary care, so hospital admissions, outpatient attendances, accident and emergency. We work with prescribing and death records, and then also with COVID testing and vaccination data, cardiovascular disease registries, and in the case of DataCan, also with the cancer registrations data sets as well. So hopefully this shows a lot of overlap with the data sets that we will have access to as part of the ScottisH Medical Imaging Project. I'm thinking in particular the secondary care data sets, prescribing data, and the death records. So we hope that the knowledge, skills and resources that we've developed stand us in good stead to support the work of the ScottisH Medical Imaging Project, and by extension the medical imaging theme led by Michelle. So just in terms of data curation and the project journey for research, a typical journey might look a bit like this, running from developing a project proposal and protocol, curating the data required for the analysis, carrying out the analysis, and then generating research outputs. And as seen on screen at the bottom there, it's been estimated that up to 80% of the work for data science with NHS records can be spent on this data preparation and curation phase. So one of the main motivations for our team is to reduce the amount of time spent on this phase of a project and to speed up the researcher journey. In terms of what we mean by data curation, we mean the process of filtering, summarizing, reshaping, and combining data from multiple data sources into a single analysis-ready data set that has been designed to answer a specific research question for a project. And this process can involve data exploration to understand data sets and to make sure they are used correctly, data phenotyping to identify patients with relevant healthcare outcomes and to develop code lists to identify these patients, data cleaning, data harmonization, and importantly, an emphasis on inbuilt checks and quality assurance of data as part of the pipeline. So just to show a typical pipeline, this is an example taken from CVD COVID UK, and you can see there's around 20 notebooks covering various stages of the pipeline, running from parameters where we set study start and end dates, defining phenotyping code lists, cohort selection, quality assurance of data, flagging linkage anomalies, for example, and other features or anomalies in the data, identifying key patient characteristics from across multiple data sources, and then identifying covariates, exposures, and outcomes for the cohort of interest, and finally producing data checks. So our team develops resources to support researchers in the data curation phase of their projects. So, for example, within the CVD COVID UK COVID Impact instance of the NHS England secure data environment, we have notebooks which include coding tutorials, dataset summaries, and data insight notebooks, which we use as a mechanism to share our knowledge of the data sets that researchers are working with, and in particular, any dataset limitations or features of a data set that researchers should be aware of before using on a project. And on screen here, we have some examples of data insight notebooks that we've developed for our primary care data in the NHS England SDE. We also have code repositories which contain all of the project pipeline code, and our team is also now in the process of developing a common code repository that will centralize code and make it easier for researchers to find and reuse, and so to promote best practice. We've also generated a number of curated research-ready data assets for frequently used data that researchers can incorporate into their data curation pipelines. And some examples of these include a key patient characteristics table, where this has been built by harmonizing data from across 5 data sets to optimize completeness and quality. We have documentation on the asset provided on our team's GitHub documentation page. Another frequently used example would be the hospital admissions curated asset, where we have cleaned and reshaped the diagnostic and procedure coding from wide into a long format, making the data more efficient for codeless matching when phenotyping and creating covariates, exposures and outcomes for a cohort of interest. And just to emphasize that almost all the projects we support make use of these curated asset, and this we hope helps promote consistency, accuracy, but also saves different research teams from having to reinvent the wheel and from producing and running code that effectively produces the same outputs and results. Also, we produce resources outside of the secure data environment. So our team has built dataset summary dashboards, which provide an overview of each dataset that's available within the SDE, and users can then explore this to see overall counts, and they can search through data dictionaries. They can look at the time period covered by different data sets, and they can look at completeness plots for the variables within data sets as well. And they can also compare the data coverage of different data sets within the environment. We've also produced a codeless comparison tool, which users can use to compare code lists from the HDR UK phenotype library, from OpenSafely's open code lists, and also from any custom text or CSV file that they upload. And they can use this to compare code lists from across different code terminologies, across different data sets. And the tool includes the prevalence of the codes within the NHS England environment. And so researchers can explore what they might expect to get from their code lists, and so select an appropriate code list for their project. Finally, we also export code from the secure data environment to our BHF Data Science Centre GitHub, making it more widely available to researchers who don't also have access to the research environment. So yeah, just on screen on this final slide, some ways that we hope we can support the Scottish Medical Imaging Project are by developing essentially equivalent resources, such as data summaries and data insights to allow users to explore and understand what data is available in the Scottish Medical Imaging Safe Haven, and maybe an equivalent dashboard to what we've produced for the CVD COVID UK consortium. We aim to develop reusable code and curated data assets that can be used by researchers. I believe that we can assist with project feasibility scoping, partly by using these insight notebooks and by using the data summaries. So we can help researchers explore whether or not we have the data we need for them to be able to carry out their projects and do that feasibility scoping. And finally, just by being on hand to provide data curation guidance and support to researchers as well. So yeah, it would be great to hear in the discussion about the types of data explorations, summaries, code or resources that would be useful to researchers to help them plan and to carry out their research with the medical imaging data set. So I'll stop sharing there and pass back to Michelle.
Fantastic. Thank you, John. And data curation for imaging research is so important. And for anything involving nationally collected research data set, as you've seen from John and Jonathan's projects, it's fundamental. And it really does take time. And hopefully with this project and with the help of John and his team, we'll be able to increase the quantity, but also the quality of imaging research being done with these data sets. Okay, so I'm sure everyone on the call knows how important cardiovascular disease is. 7.6 million people in the UK are living with it. Medical imaging, crucial in diagnosing and managing cardiovascular disease. Routinely performed imaging is done in many patients around the country every single day, but we know that it's underutilized in cardiovascular research. And when I started as Associate Director at the BHF Data Science Centre, our first workshop, we looked at some of the reasons for that. Difficulties identifying it, obtaining access to it, linking it, collecting other information. There's lots of barriers to this. And the aim of this project is to try and address that. So the SHIELD-CVD project aims to enhance the SMI datasets, accessibility and applicability for cardiovascular research so that we can kickstart some research with this dataset, but also use that learning and curation code to transfer to other datasets so that other datasets can be used in more and better ways as well. So some of the specific things we're going to do, we're completing the application and governance paperwork, and we're going to make that available to other researchers and make exemplar examples of what the patient and public benefit panel are looking for, so that that application process is speeded up. We're going to focus on cardiovascular disease excluding the brain, because as you've already heard from Will, the brain health pilot is looking very much at the brain. We're going to do similar and overlapping things looking at the rest of the body. And working together synergistically using learnings from both projects to make the most of what we're doing from a research point of view. So they're doing similar and overlapping things, but in different bits of the body. We're going to use the imaging metadata, imaging reports, and linked other records of all of the different types that are available from Public Health Scotland to assess the number and types of cardiovascular imaging tests that are available, what is available within that imaging, sequences, reconstructions, details of the metadata, and also look at demographic characteristics and comorbidities of patients so we can identify the number of cardiovascular and types of cardiovascular diseases that are represented. As you've heard from John, we have plans to develop reusable code and reusable resources for data curation and analysis to really help kickstart research, but also to generate phenotypes, which will help people with a starting point for their disease. We're going to perform some more detailed exploration of coronary artery disease, take the learning from the English data sets and try and apply that in the Scottish data sets, and use that as an exemplar project to explore what information is available and what is needed for other types of research. And we also want to create a community around the use of using this data for sharing learning, sharing resources, and really do a team science approach to maximize the research that can be done in this data set. Hopefully that gives you a bit of an idea of what the data set is, what the potentials for research are, both now and in the future, how this overlaps with other things that we're doing in different data sets throughout the UK, and what gives you an idea of what sort of research might be possible that you might be interested in doing with this data set. So what we'll do now is we will have a discussion about what information you would like to find, what sort of research you would like to do, what resources and things that you think the data scientist team can put together that would be useful for you. We would like to chat about sharing and reusing research-generated objects that you might make as part of this research, and any other questions or suggestions.